Hey, we have our final pre-lecture recording where the focus is going to be on substance use disorders today. We are hopefully going to be able to get through this, even though I know there are a lot of slides. I think some of them will go pretty quickly, and hopefully we will be able to avoid another 40-minute pre-lecture recording. I have a lot of suggested reading here, and this is really just to break up. The first section is to be focusing more on alcohol use disorder. Obviously, anything additional would be optional. And these are not, just to specify, these recordings or these readings are not required. They're all suggested. So please ignore the fact that this says required on this slide here. I also have added a couple extra things that, if you're really interested or you want to learn more about this, are really helpful. Something I make all of my APPE students read is this paper by Volkow and colleagues on the neurobiological model of addiction as a brain disease, and then the effects of chronic alcohol use on the body. So there are a lot of objectives for this lecture, and what's might be a little bit complicated, but hopefully we'll get through it just fine, is that we're actually going to cover a little bit of all of these objectives in the pre-lecture, and then we're going to cover the rest of them in the in-class lecture. So if this doesn't work, I would love your feedback. If all of you can let me know how this goes, or if it does work, great, let me know, please. So by the end of the lecture, once you've seen the pre-lecture and the in-class lecture material, you'll be able to recall general diagnostic criteria for substance use disorders, describe pharmacology of alcohol and opioids, discuss the pathophysiology of alcohol withdrawal, summarize signs and symptoms of alcohol and opioid intoxication and alcohol and opioid withdrawal, list risk factors for alcohol withdrawal delirium, that's abbreviated as AWD, and opioid overdose, and then recommend pharmacotherapy regimens for withdrawal from alcohol, for treatment of alcohol and opioid use disorders, and for opioid overdoses. So before we get into all the details, I'd like to kind of overview the disease model of addiction, and this is really just a simple overview, but I really like to make sure that everybody's on the same page, and that I've been able to convince all of you that not only are all psychiatric illnesses chronic diseases, but addiction is also a chronic disease, not a moral failing of people. So it's important to remember that people with addictions never decided when they were 5 years old that they wanted to grow up and become addicted to heroin. That was never their choice, and that they didn't, they're not going through life choosing to keep up with that addiction. And so if we consider the disease, the definition of just a simple disease, we realize that it actually does model the same pathway as addiction. So a disease is a deviation from or an interruption of a normal structure or function of any part, organ, or system. So we can say in addiction that's the brain, or any combination thereof. So the deviation from interruption or normal structure of function of any part, organ, or system of the body that is manifested by a characteristic set of symptoms and signs, and we'll go through those, and whose etiology, pathophysiology, and prognosis may be known or unknown. And so we could definitely say that addiction, as well as other psychiatric illnesses, do meet this definition of a disease. So now into the criteria. This is a list of the diagnostic criteria for just general substance use disorders. If you were to open up the DSM-5 and look up the substance use disorders chapter, you would see that it's broken up into different diagnoses for each individual substance that somebody could become addicted to, and I've just kind of combined them into this more simple structure because for the most part, they're all pretty much the same. It's just that when you say, when it's referring to the substance, that means that it's whatever substance that the person is particularly addicted to. So the substance is taken in larger amounts or over a longer period than intended. The person has a persistent desire or has made unsuccessful efforts to stop or reduce use. They have spent many hours, days, months, years trying to obtain or use the substance or to recover from intoxication on that substance. They experience cravings to use the substance. They are failing to fulfill major obligations due to recurrent use. They have continued use despite negative social and interpersonal problems. They've given up important social and occupational and recreational activities. They use recurrently whether it is hazardous physically or not. They use despite negative physical or psychological effects. They've developed tolerance for the substance, so they need to use more and more in order to get the same effect. Or they get less effect with the same amount that they had been using up until then. And they also might have withdrawal, which is the syndrome that is specific to the specific substance, or people that are using in order to avoid symptoms of withdrawal. Substance use disorders are divided into different severity criteria. So if a person meets 2 to 3 of these criteria, they have a mild substance use disorder. 4 to 5 is moderate, and severe would be meeting 6 or more of these criteria. So I also want to recap just back to when we talked about stigma during the first lecture, and revisit that just a little bit again, because there's a lot of old terminology that's used when talking about patients with addiction, and it's really not great that we continue to use it. And it's because it's for various reasons, this language really needs to kind of be omitted from our vocabulary. And so you'll see me say things like misuse, and the reason I say misuse is just because it doesn't sound as bad as abuse, but I try to use that not very often. The word abuse is not, so neither misuse or abuse are recognized in the diagnostic criteria. The reason for that is that they're vague, so we have no idea what that even means, really. And then, of course, there's a very negative connotation with the word abuse. I think I talked about this in lecture, where the word abuse brings up a lot of very negative things in most people's minds. And automatically, and they've actually done some stigma research showing that when people are identified as substance abusers versus people identified as having a substance use disorder, clinicians, legal or law enforcement, a whole bunch of different types of people will recognize the person as a substance abuser as somebody deserving of criminal ramifications for their actions, whereas maybe somebody with a substance use disorder as somebody deserving of treatment. And so because of that distinguishing feature, we're really trying to get people into identifying people with addictions as people with substance use disorders and really omitting the phrase substance abuser from their vocabulary. It's also important to remember that tolerance and dependence are not interchangeable with addiction or with substance use disorder. Even though tolerance and dependence/withdrawal are part of the diagnostic criteria, if somebody has tolerance and dependence on a substance, that does not mean they are addicted to that substance. It just means that they're physically tolerant and physically dependent on that substance. And you can think of a variety of other types of medications or other substances that people use where they become tolerant or dependent of them and have no symptoms whatsoever, or none of the other symptoms at all of addiction. So for instance, if somebody starts a selective serotonin reuptake inhibitor, and when they first start it, they're a little bit nauseous, and after 4 or 5 days, that nausea goes away and they're able to tolerate the medication. Well, they've just developed tolerance. And then if they're on it for several months at a time and they stop it all of a sudden, they might have withdrawal symptoms. So that means they're also physically dependent on it. However, they're not demonstrating any of the other signs and symptoms of addiction, and so we cannot identify them as being addicted to that antidepressant. And then, just as a rule of thumb, never call patients with substance use disorders addicts, drug abusers, or junkies. It's not medical, so we shouldn't be using that kind of language at all as pharmacists, but it's also very demeaning and marginalizing to this patient population. What are the risk factors for developing a substance use disorder? Well, there are lots of cultural attitudes in different parts of the world that might increase someone's risk. The other thing to think about is there are different parts of even the country and other parts of the world where using certain substances is very common. So, for instance, my PGY2 residency was in Wisconsin, and Wisconsin is a state where everybody drinks in pretty high quantities. And so the culture there is to drink alcohol, and it's normal to drink kind of a lot of alcohol. And so it kind of goes along with that we would expect to see a lot of alcohol use disorder. And sure enough, we do see a lot of alcohol use disorder in Wisconsin. So certain cultural attitudes in certain states or around the country might lead us to see a lot more of other types of substance use disorders. If people start using at an early age, they're more likely to develop a substance use disorder. So they may only use periodically when they're young, but if they're starting to use when they're 12, 13, 14, that's much more indicative of developing an addiction later on. People who have early evidence of aggressive behavior, people with intrafamilial disturbances, people, depending on their environment, if there's a lot of substance use among their peers or within their family, they're more likely to end up addicted to substances themselves in the future. If their family members have a history of a substance use disorder, and if there are other psychiatric comorbidities within the patient. So we'll start off by talking about alcohol withdrawal syndrome. When we talk about alcohol withdrawal or just alcohol use disorder, it's important for us to consider what a standard drink is. And so these definitions are pretty important to know that 12 ounces of regular beer is a standard drink, which is about 5% alcohol. So if you're talking about the craft beers that are like 9, 10, 11% alcohol, one 12-ounce beer of those is actually considered to be 2 standard drinks. 8 to 9 fluid ounces of malt liquor, which is about 7% alcohol, is considered a standard drink. 5 full ounces of table wine, and 1.5 ounces of spirits or hard alcohol. Also, each of those are standard drinks, and so it's really important when interviewing patients and talking to them about their alcohol use to make sure that you have an idea of how many standard drinks they're having, not just whatever it is that they tell you. Because sometimes people will say, well, I have 2 drinks a night, but then you find out that they mean that they're having 2 40s of Colt 45 or something, and that's like 10 drinks. So the other thing to remember is that alcohol is in fact a drug. There is a dose-dependent central nervous system depression that occurs with alcohol, and it affects a variety of neurotransmitters. One of the major ones that it affects is GABA, and so if we remember that GABA is the primary inhibitory neurotransmitter in the brain, we see that it upregulates GABA quite a bit and causes a lot of that, the slowing down of the central nervous system. It also indirectly affects, alcohol indirectly affects glutamate and dopamine, and we'll see how that is affected in a minute. So what is alcohol doing? So it absorbs really quickly within the body. It only takes about 10 minutes to start absorbing through the stomach lining. Body fat does not absorb alcohol. Alcohol effects peak somewhere between 30 and 90 minutes after the most recent drink. And it depends, that the peak of the alcohol depends on the type of alcohol, whether or not somebody has food in their stomach, and a variety of other factors. Alcohol does distribute freely throughout the body, and it rapidly crosses through the blood-brain barrier. Alcohol is metabolized mostly by the liver, about 90%, via alcohol dehydrogenase. And so that's what we always think of when we think about if there's liver damage. Well, is there chronic alcohol use or something going on there? The remainder of alcohol is eliminated by the lungs, the urine, and sweat. So when we're talking about the neurotransmitter involvement with alcohol, if somebody isn't using alcohol at all, they have normal amounts of GABA and glutamate activity. So this is baseline. If somebody has acute alcohol use, so maybe they do 5 shots of alcohol, then they have a huge upregulation in their GABA activity. And so because alcohol itself acts on the GABA receptor and causes a major increase in GABA activity. If somebody continues to drink over a period of time, their natural GABA activity, which is the bluer region box that I'm using with the arrow, or highlighting with the arrow over here, their natural GABA activity actually reduces, and that's because the person is providing this external source of GABA activity with alcohol, and so the body says, well, if you're going to supply it, then I'm not going to make it. And so the body just starts counting on this alternative source of GABA activity. Then, because the body's being slowed down just way too much with all of this GABA activity, the body starts upregulating its glutamate activity. And so you have this compensatory, excitatory response through glutamate. So what happens is when you abruptly stop alcohol, you then get rid of all of the external source of the alcohol, and you only have this small amount of GABA activity that the body has been kind of slowly producing. Yet you now have this uncompensated glutamate overactivity, and so you have this expression of an excitatory neurotransmitter that causes a whole assortment of problems later on down the line. So if you look at this, there's a certain amount of GABA agonism that's needed to override glutamate activity. And so when we're treating alcohol use disorder, what we're trying to do is actually cover up all of this glutamate overactivity with other types of medications that will slow down the brain and will activate GABA again. So, in alcohol withdrawal syndrome, which is abbreviated as AWS, there's quite a bit of neurotransmitter dysfunction like we just talked about. In uncomplicated alcohol withdrawal, you just have that reduction in GABA activity that wasn't there previously. So while there was an overproduction of GABA activity and then you stop using alcohol and then you get this underproduction of GABA, and that just leads to uncomplicated alcohol withdrawal. However, if we get into complicated alcohol withdrawal, which is a variety of different symptoms, the first of which is highlighted here, which is an alcohol withdrawal seizure, you have the increased glutamate activity that's not compensated by GABA, and when you have that increased uncompensated glutamate activity, you can end up with a seizure. Then if you add in increased dopamine release, which can happen in response to the increased glutamate activity, you can also end up with alcoholic hallucinosis. And then the most complicated picture is when somebody develops alcohol withdrawal delirium, where you also have the adrenergic or noradrenergic, increased noradrenergic activity, and so the person's norepinephrine, dopamine, and glutamate are all overactive, and they're not compensated by anything slowing them down because we have decreased GABA activity, and we have very complicated alcohol withdrawal and alcohol withdrawal delirium. And so what do the symptoms of these different states look like? So in early or uncomplicated alcohol withdrawal, which takes, it's somewhere within the first day, maybe day and a half of withdrawing from alcohol, somebody might report anxiety, they might have a fine tremor, they'll have tachycardia or increased heart rate, they may report headache, heart palpitations, reduced appetite or anorexia, GI upset, and overall general malaise. This is maybe what you would consider a very severe, what would look like a very severe hangover if you're not dependent on alcohol. In the cases of seizures, you tend to see with alcohol withdrawal seizures people having generalized tonic-clonic seizures or status epilepticus, which is quite rare, and that also happens within the first 1 to 2 days of stopping alcohol. In alcoholic hallucinosis, people will be reporting visual, auditory, and or tactile hallucinations. Much more common to be hearing about visual and tactile hallucinations, and those are things that we're not as used to hearing when we're talking about patients with psychotic or psychosis. That also tends to happen within the first 1 to 2 days of alcohol withdrawal. And then finally with delirium tremens, we see delirium so completely out of touch with reality and not attending to appropriate stimuli. People with tachycardia, hypertension, agitation, fever, a lot of sweating, and having a coarse tremor. And that happens more like 2 to 4 days of stopping using alcohol. Risk factors for alcohol withdrawal delirium include a history of having past seizures or delirium tremens. So if you have previously had complicated alcohol withdrawal, you're more likely to have complicated alcohol withdrawal again in the future. If you've had a seizure prior to admission, if you have acute concurrent medical illnesses, if you've had more days since your last drink, so that kind of underscores the fact that alcohol withdrawal delirium is more likely to happen in that 2 to 4 day window as opposed to within the first 1 to 2 days. If you have an elevated admission blood alcohol content, and what that speaks to is the fact that people who present to the emergency department who are incredibly intoxicated, their blood alcohol content might be 0.4 or 0.5, and they're walking through the door saying like, I need alcohol detox. In normal people, that would make them unconscious or actually kill them because of alcohol poisoning. However, for them, they're so tolerant that they're totally fine. Well, their risk of developing very severe alcohol withdrawal is actually very high because they're so physically dependent on alcohol. If people have a heavier or longer drinking history, they're more likely to have alcohol withdrawal delirium. If they have symptoms of autonomic hyperactivity, so that's that increased noradrenergic activity with the blood alcohol content greater than 0.1. And what that's speaking to is even though their blood alcohol content says that they're intoxicated right now, we're already seeing some symptoms of withdrawal, which is that autonomic hyperactivity. And so if we're already seeing symptoms of withdrawal when they're intoxicated, we can only expect that those are going to get worse the more that we reduce the level of alcohol in their body. Older age or age older than 40, Anybody having burn-related injuries or falls, especially with long bone fractures, are more likely to develop delirium. Relevant things to be kind of assessing in people with alcohol withdrawal delirium, not only their risk for developing delirium, but also their risk of sedation and their risk of respiratory compromise. So just some things you'll want to consider when thinking about alcohol withdrawal delirium are a lot of those things that would increase somebody's risk. So those were on the previous slide. And then when it comes to sedation, thinking about elderly adults, people with hepatic dysfunction, people who are on other CNS depressants, so opiates are a big factor that might increase the risk of sedation. People who've had a head injury or recent administration of benzodiazepines or concurrent administration of sedatives. So again, a lot of this is other CNS depressants that would just increase the risk of sedation. And then risk for respiratory compromise would be people who have a concomitant diagnosis of pneumonia, people with rib fractures or who have a chest tube, pulmonary contusions, or a C-collar or a brace. So in managing alcohol withdrawal delirium, we'll talk mostly about this in lecture, but this slide is just to kind of give you a quick overview of the things that we address. So we'll do some pharmacologic management to really cover that, trying to compensate for the reduced GABA activity within the brain and trying to compensate for the overactivity of the glutamate in the brain. Augmentation agents to get after that autonomic instability. Supportive care for anything else that we might be seeing, specifically thinking about dehydration and nausea, so on and so forth. And then prophylaxis of some brain diseases that can happen in people that have chronically used alcohol at high amounts for too long, like Wernicke's, which we'll talk about when we get into lecture. So now we'll go on to alcohol use disorder. The incidence of alcohol use disorder is pretty high. It's almost 1 in 10 U.S. adults meet criteria for some sort of alcohol use disorder. And according to the National Survey on Drug Use and Health data from 2011, which is quite a while ago, but it's the most recent that we have, about half of Americans older than 12 drink alcohol, and about a quarter of them participate in binge drinking. About 6.2% of the U.S. population report heavy drinking, which for males is more than 4 drinks at a time, and for females is more than 3 drinks at a time. And men tend to report alcohol use disorder and binge and heavy drinking more than women, but women tend to be more likely to seek treatment. For the etiology and pathophysiology, the way that people become addicted to alcohol is that the alcohol-induced euphoria ends up being enhanced by the dopamine reward system. So when we drink alcohol, our body releases a bunch of endorphins, and endorphins are our body's natural opioids. And those opioids end up binding to opioid receptors, which then cause a huge release of dopamine in our reward pathway. And when that reward pathway is kind of fired up, that causes our brain to remember forever that, ooh, alcohol helps us feel a certain way that maybe we really like. And when it's something that we really like, then it makes us want to do it more and more and more, so it reinforces more use, and it kind of starts a very vicious cycle of addiction. GABA and glutamate are also affected by alcohol consumption. We already talked about how they play that role in withdrawal symptoms. So there's a lot of acute effects of alcohol use. I won't go through these all individually, but we know that early on, alcohol may just cause a little bit of euphoria, maybe some reduced inhibitions, and then as people get more intoxicated, we start to see lack of motor control and physical control, maybe blurred vision, difficulty balancing. Once we get pretty intoxicated, people will start feeling more dysphoric and maybe having worse or lower mood, some symptoms of anxiety, maybe even some nausea. So these are, again, this is for normal people that are not already physically dependent on alcohol. So this is mostly people without alcohol use disorder. Once we get to a BAC of 0.3, typically we should expect to see a loss of consciousness, and at greater than or equal to 0.4%, we would expect somebody to be starting to be in a coma or maybe even death caused by respiratory compromise. The effects of chronic alcohol use are wide and varied. So there are lots of CNS problems that can happen. People will develop memory impairment, more likely to develop dementia earlier on. People can have withdrawal seizures, peripheral neuropathy, ataxia, which is difficulty with balance and walking, significant insomnia, and then Wernicke-Korsakoff. There's lots of cardiovascular problems that can happen with alcohol use, heart palpitations. People can develop cardiomyopathy and heart failure, hypertension and anemia, which is denoted by the increased mean corpuscular volume on the CBC. People can also have GI problems, lots of dyspepsia, nausea, vomiting, diarrhea. Pancreatitis is one of the most common reasons for people to come to the emergency department. GI bleeds are quite common, and of course, liver disease because it metabolizes alcohol. So Wernicke syndrome and Korsakoff psychosis. So these are two different disorders that are very related. Both of them are caused by thiamine deficiency. When we have thiamine deficiency, that leads to eventual cell death through a huge cascade that we don't need to get into. The cell death eventually will cause injury to the brainstem in areas near the third and fourth ventricles. So with those damages, we start to see Wernicke syndrome. And the symptoms of Wernicke syndrome include confusion, delirium, nystagmus, and ataxia. These two tend to be some of the classic symptoms, as well as, the confusion, delirium, nystagmus, and ataxia all respond rapidly to vitamin or to thiamine replacement. So Wernicke syndrome is a reversible syndrome. Korsakoff psychosis, however, is sometimes not reversible, and it's a later manifestation of Wernicke's. And so what happens is somebody develops Wernicke's, doesn't get their thiamine replaced, and eventually is now developing or showing signs of Korsakoff psychosis, where it looks like people are severely disoriented and really out of touch, developing delirium and being out of touch with reality and not able to reverse that with repletion of thiamine. People having memory loss as well as confabulation. And confabulation is a classic sign of Korsakoff psychosis. It's a very interesting sign, and it's what happens is that people will start to just make up words and make up stories that don't fit along with any part of their history. So now on to opioid use disorder. So as most of you may know, opioid use disorder is now a national epidemic, and we are just continuing to see rising rates of overdose deaths. So this chart is just showing the increasing rates of deaths from prescription opioid overdose, whereas this one shows rapidly increasing deaths from heroin overdose, particularly over the last 5 years. Why is that increase happening? Well, a lot of it started with the way that opioid prescribing has changed over the last 30 or 40 years. So before the 1980s, we had potent opioid analgesics, similar to everything that we have today. However, they were only limited to people being treated for severe acute pain or people with malignant pain or people under palliative care. Between the 1980s to maybe early 90s, we started seeing a lot of increasing reports of undertreated pain. And so in the 90s, a lot of the drug companies started getting on board with, yes, a lot of people have undertreated pain. They started the Pain is the Fifth Vital Sign campaign. And we started to see a lot more attention paid to the burden of undertreated pain. And then we started seeing a lot more opioid prescriptions increase. Then in the early 2000s, opioid prescriptions continued to be on the rise. However, we did start a little bit to see concerning increases in opioid-related deaths. Now, in the 2010s, we have seen an alarming increase in opioid and especially heroin-related deaths, and we do think that it is related to the whole pain is the fifth vital sign and increased opioid prescribing. However, of course, there are other factors. So what those are include pharmaceutical industry advertising, criminalization of substance use disorders. So what we know now is that when we lock people up because they've been caught with using a substance, it doesn't help them and in fact is more likely to really cause a detriment to their future, both from, of course, the social and occupational functioning standpoint, but then also from their recovery. Heroin is really cheap, and it's really cheap and easy to get. And so what we see, unfortunately, a lot is that people get started on a prescription opioid, their physician gets uncomfortable continuing to prescribe it after a period of time, so they just stop prescribing, and then the person realizes that they can't afford the cost of street pills, and so they then go to heroin, and it's unfortunately just way too easy for people to make that transition. And then we also are seeing a huge increase in deaths because of fentanyl analogs that have been released more recently within the past 5 to 10 years. The the difference between, so fentanyl actually looks quite different from heroin if you were to look at the two powdered substances. Heroin is more of a brown powder, and fentanyl is like this very white powder. The way that people get fentanyl, sometimes nowadays we have some people that are intentionally trying to use fentanyl. However, most of the times we end up seeing people that are using some sort of brown powder that has been mixed, or they call cut, with fentanyl, and it may or may not contain any heroin at all, but they're getting a lot of fentanyl and overdosing because of it. Risk factors for overdose include people who are also taking other CNS depressants, people who have developed or are demonstrating addiction behaviors, people who lack insurance or who are enrolled in Medicaid, people who don't have access to treatment, so they're lacking treatment for their addiction, and those people are definitely more likely to overdose. People who've had a period of abstinence. Now this one's a little interesting, but people who've gone a period of time without using, then lower their tolerance that way. And when their tolerance is lowered, that means that they only need to use a little bit of the substance that they used to use before in order for them to achieve the same effect that they were using before they started being abstinent. But unfortunately, what happens a lot is that we have people who will say that they stop using, they don't want to use again, and then they will go maybe a couple weeks, maybe a couple months without using any substances at all, and then they'll pick up again and they'll start using with the same amount that they used previously before they ever started being abstinent. And when they do that, then they're much more likely to overdose because their body's tolerance has been reduced so much. We also see increased risk in patients who are non-Hispanic Caucasians, people who are males, people living in large metropolitan areas, and younger people between the ages of 18 to 25. What are the effects of opioid use? Some of you may be familiar with these, maybe in other courses or CDM components when you learned about pain, but in the short term, opioids cause analgesia or pain relief. They cause euphoria, or what some people refer to as the high. They cause sedation. They can also cause respiratory depression, which is how people actually overdose on them. Their respiratory drive reduces so much so that their lungs no longer have the desire to take a breath, and that can then lead to death. There are also long-term effects of opioid use, so people develop tolerance, dependence, addiction, of course, but then you see also reduced analgesia, so they have actually, what happens with opioids is that they don't control pain as well as they used to when they first started to be used, and then they may also cause pain, which is hyperalgesia, and so people will start to feel pain in places where they normally wouldn't, and feeling pain after experiencing things that normally wouldn't be painful, like somebody just maybe rubbing the back of their hand might feel painful to them when normally that shouldn't feel painful. Long-term use of opioids also cause low testosterone, constipation, sedation, respiratory depression. So you see some of these happen both in the short term and the long term, and you don't develop tolerance to these. You can also see death, endocarditis, cellulitis, osteomyelitis, and a variety of other types of infectious diseases, all due to IV or subcutaneous injection use. Withdrawal symptoms of opioids they happen pretty quickly, and it really depends. This says upon abrupt cessation after about 2 to 4 weeks of daily use. So people become tolerant and physically dependent on opioids fairly quickly after starting to use them. And if they abruptly stop, their withdrawal symptoms might include restlessness, musculoskeletal, which is what MS stands for here, musculoskeletal pain, insomnia, nausea, vomiting, diarrhea, goose flesh, and autonomic dysfunction, so increased blood pressure and heart rate and all of those things. While these symptoms appear in this list to be not very severe, it's important to know that people who are experiencing opioid withdrawal feel like they're dying. These symptoms feel so incredibly severe, and people feel like they cannot manage them whatsoever. And so it's just important to have that in the back of our minds when we think about, well, why do people keep using? That's part of it. So that concludes the substance use disorders pre-lecture material, and I'll look forward to continuing this in lecture.